In 2011, global health programs began rolling out a new technological baseline for tuberculosis diagnosis. They deployed rapid molecular testing platforms across high-burden countries, significantly accelerating initial disease detection. While this modernization improved initial detection, it inadvertently triggered a decline in a separate, vital function. We enhanced our ability to identify the disease, but we compromised our capacity to monitor if the treatment actually works. Medical protocol defines TB treatment monitoring as systematic longitudinal bacteriological assessment. It is the only way to distinguish a true bacteriological cure from a mere clinical assumption of cure. The World Health Organization protocol requires testing patients with drug-susceptible TB at month 2, month 3, month 5, and at the end of their treatment cycle. This process relies on a different biological question than initial diagnosis. Detecting a disease on day 1 does not prove that the bacillary load is actually clearing over the subsequent 6 months of therapy. This monitoring capacity is currently collapsing across all 30 of the WHO's high-burden countries. By prioritizing initial diagnostic speed over longitudinal confirmation, health systems have created a massive clinical blind spot in patient care. Data from 2023 shows that global bacteriological confirmation of pulmonary TB has stalled at 62%. In Angola and Mozambique, confirmation rates have fallen to 41 and 44%, well below the 50% crisis threshold. Here, the rapid adoption of molecular tools correlates with a near-total erosion of data required to track patient recovery. Without laboratory data, doctors are forced to rely on crude clinical indicators, monitoring whether a patient is gaining weight or reporting a reduced cough. Relying on clinical impression alone removes the objective evidence needed to confirm that the prescribed drugs are effectively killing the bacteria. For over a century, sputum smear microscopy served as the universal monitoring backbone for tuberculosis programs. It was operationally efficient. Each test cost only $1 to $2, yielded same-day results, and could be performed at rural, peripheral clinics. Microscopy has known biological limits, including a sensitivity of only 50 to 65% in patients with low bacterial loads. In 2013, the WHO officially recommended molecular diagnostics as the superior initial test for diagnosis and resistance detection. Following this, national programs shifted their budgets to cover the cost of molecular machines and cartridges. They systematically decommissioned microscopy infrastructure, leaving peripheral clinics without the tools for follow-up testing. This diagnostic upgrade defunded the only universally accessible monitoring tool without providing a functional successor for the monitoring role. If molecular testing is now the standard, the question is why we cannot simply use those same machines to track a patient's recovery. The problem is the foundational mechanism of DNA-based PCR assays. These tests are designed to detect any presence of mycobacterial DNA in a sample. When anti-TB drugs kill the bacteria, the living organism dies, but its genetic debris remains. Persistent DNA fragments can stay in sputum for months. This graph illustrates the difference in decay rates. While DNA persists in the lungs long after treatment begins, RNA degrades rapidly following bacterial death. A 2024 validation study in the Lancet Microbe mapped these exact degradation curves over a full course of treatment. The study found that using DNA-based molecular tests at month 6 of treatment resulted in a 33% false positive rate. In practice, this means 1/3 of successfully cured non-infectious patients would be incorrectly flagged as failing their treatment.
This is why the WHO and CDC are unequivocal. Molecular DNA tests must never be used for treatment monitoring. Molecular positivity is biologically unlinked from true bacillary viability, rendering these expensive diagnostic networks useless for longitudinal monitoring. To test for viability, programs currently rely on the gold standard, MGIT liquid culture. Liquid culture is highly sensitive, detecting only the living, viable TB bacilli that a DNA test cannot distinguish from debris. However, this method requires specialized biosafety level 2 or 3 laboratories, constant power, and highly trained staff. The costs, between $20 and $50 per test, are prohibitive when applied to a standard monitoring schedule that can last up to 24 months. Furthermore, liquid culture requires a 4 to 8 week incubation period before a result is available. By the time a month 2 culture result arrives, the patient is already deep into their 4th month of therapy, making the data too late for a clinical intervention. The biological accuracy of liquid culture is negated by its logistical weight in high-burden healthcare networks. Patients in this monitoring vacuum may be failing their treatment without anyone realizing it until their clinical condition worsens significantly. Data shows that up to 1 in 5 smear-positive patients with drug-susceptible TB do not actually clear their bacteria by the 2nd month. Without monitoring to trigger a change in care, these non-converting patients remain on ineffective regimens, allowing the disease to persist. This crisis is most acute in multi-drug-resistant TB, where monthly culture is mandated but rarely accessible in resource-limited settings. When treatment failure goes undetected, the patient remains on a subtherapeutic drug regimen. This exposure actively selects for resistance mutations in the surviving bacteria. Initial molecular diagnostic tests cannot flag these secondary resistance mutations that emerge after treatment has already begun. In the absence of bacteriological monitoring, the system is actively engineering untreatable superstrains through prolonged, ineffective drug exposure. A potential solution to fill the monitoring vacuum is an emerging technology called TB-MBLA. This assay uses reverse transcriptase qPCR to target 16S ribosomal RNA rather than persistent DNA. Because it targets RNA, it provides a direct and accurate measure of the viable bacillary burden in the patient's lungs. Performance metrics show the assay achieves 94% sensitivity compared to the culture gold standard, but delivers results in just 24 hours. This speed allows clinicians to detect log-scale changes in bacterial load within days of starting treatment. Real-world hurdles remain, including the need for a negative 80 degrees Celsius cold chain and a lack of large-scale commercial manufacturing. The scientific solution for the monitoring crisis exists in research pilots, but it has yet to be integrated into the global procurement architecture. National TB programs must take immediate steps to close this monitoring gap. This requires rapid laboratory audits and the immediate operational reinstatement of smear microscopy capacity alongside molecular tools. The WHO and global partners must establish minimum culture access standards for high-risk patients through specimen referral networks. Procurement agencies must also prioritize negotiated pricing and manufacturing scale-up for RNA-based monitoring assays. The End TB strategy cannot succeed if cure is declared without confirmation. We must ensure the science used to treat the disease is matched by the science used to monitor it.